Hi, everyone, and welcome to this last session of the TechNet 21 webinar series on reaching zero-dose children. The topic today is urban immunization, and Ibrahim will introduce you to the panelists in a minute. You can listen to this presentation in French. To do so, please select the globe at the bottom of the Zoom window and choose the desired language. If you struggle to find it, please do let me know in the chat area. I'm going to say that in French for our francophone colleagues. Bonjour, vous pouvez écouter cette présentation en français. N'hésitez pas à cliquer sur le globe qui se trouve en bas de votre écran Zoom. Là, vous pouvez choisir la langue, français, et vous pouvez suivre la discussion en français, et vous pouvez même supprimer la voix de fond pour n'entendre que l'interprète. Talking about the chat box, you can already introduce yourselves and tell us where you are from and your name. We already have some people introduce themselves from Cameroon, Sudan, Switzerland, and more. And hi, everyone, and welcome. And I hope that you're going to enjoy this presentation. And during this presentation, if you have any question, you can use the question and answer Q&A box, which is also available at the bottom of your Zoom window. Don't hesitate to ask a question at any time. Our panelists will answer them either during the presentation in written or after the presentation orally. During the Q&A session at the end of after the presentation. Finally, this session is recorded, and we'll share with you the links to the video as well as the slides. I hope you'll enjoy this session, and I'll give the floor to Ibrahim.
Thank you, Alex. Hi, everyone. Good morning, good afternoon, good evening. Thank you for joining us on this urban reaching zero-dose children in urban settings to urban immunization. We have three panelists presenting, but I'll quickly go through some background with respect to urban immunization programming and urban work, and then introduce the panelists. So my name is Ibrahim Dadari. I work with UNICEF. I'm based here in UNICEF HQ and also the focal point for global urban immunization. Basically, the world is increasingly becoming urban. We see clusters of urban settlements with slums and peri-urban settlements brewing across the globe. And by 2050, it's estimated that 66% of the world's population is going to be urban. We have the Equity Reference Group on Immunization that has identified key areas where we have zero-dose children and missed children or communities with respect to vaccination, and urban poor is one of the major areas of focus. So there is, because there's a lot of issues, peculiarities with urban, and that's why we're focusing to make sure that universal immunization access reaches everyone, including those in the urban. So we have an urban immunization working group, and then their membership you can see at the bottom of the slide: GSI, CDC, UNICEF, WHO, and other colleagues. And this group has worked tirelessly over the years to make some modest achievements, including developing the urban immunization toolkit. Some of you are familiar with and have probably implemented it, and for those that are not yet conversant, it would be good to take this into consideration when you're planning for your program. So the panelists, well, presenters we have today are three. Ijoma Agbo from Nigeria will share the urban immunization experience in reaching zero-dose children in Lagos, Nigeria, which is one of the largest urban settlements in Africa. Nasir Mohammed will share an assessment of inequities in routine immunization among the urban poor in 4 cities in Zimbabwe. Nasir works with GSI and he's currently calling from Tanzania. Aftab is based in Pakistan with UNICEF, and he's going to share with us some of the exciting work they're doing with respect to urban immunization in Pakistan. And for today, they've selected the 24/7 bed dose initiative in Pakistan to share with our esteemed listeners. So I'll hand over this to Ijoma to start. Ijoma, over to you, please.
Thank you very much, Ibrahim. So today I'll be giving our experience from Lagos, the urban immunization experience in reaching zero-dose children in Lagos State. Next slide, please. So just as Ibrahim had mentioned, Nigeria is actually the largest country in sub-Saharan Africa, and we actually have a national growth rate of about 3.2%. We've had our urban population within the country grow rapidly over the last couple of years with an annual increase of about 4.5%, thereby showing that we've had within Nigeria about 55% of our total population living in urban areas. Nigeria accounts for a high proportion of zero-dose children in Africa. We have presently about 2.4 million zero-dose children in the country. And though we've recorded, considerable progress when it comes to vaccine coverage, we still find that zero dose remains the key problem for us. Reaching zero-dose children has become quite a priority, especially as we know that once you have zero-dose children that is unprotected, we are at risk of disease outbreaks, which we've seen crop up within the country and in a lot of our states, and particularly in Lagos State. They're deprived from the basic health services. Once you have a zero-dose child, that means most likely the mother did not have antenatal care and all that. And of course, there's entrenched gender inequality. We needed to understand the context-specific drivers of zero-dose, and that is one thing we also did in Lagos before we actually came up with tailored strategies in reaching them. Next slide, please. So I'm just going a bit into the demographics of Lagos State. So Lagos State actually has the smallest landmass of about 3,577 kilometers, but it has one of the largest populations in Nigeria. We're actually the second highest population within the country. We have approximately 14.9 million, and this is extrapolated from the census that was done in 2006 by the federal government. We have about 20 LGAs, and we have 22% of our population living in hard-to-reach areas that are characterized by lagoons, islands, swampy, and sandy areas. Another key thing I would like to point out is that we have 376 wards in Lagos State, and presently we have about 114 wards that do not have primary healthcare centers, which of course shows an access issue as well. But with our large population, we can see that even though we might have good coverage when it comes to Penta 3 or even Penta 1, we still have a high population that are not reached with vaccines. Next slide. So just as I mentioned, we have a high proportion of our communities that are considered slums. The Lagos State Ministry of Health recognizes 114 slums in Lagos State. And what is a slum? It's a settlement where inhabitants are characterized as having inadequate housing and basic services. And most times they're actually not even being recognized by the public health authorities. And I also went on to give us what the elements of a slum household is like and the challenges of immunization delivery in urban slums, which ranges from the fact that it's not a priority, they're marginalized, they're quite distant from health services and basic social services. And also, their focus is mostly on curative services as opposed to preventive. And so immunization is not seen as important to them. They're weak planning and management and coordination, and of course, supervision of activities that are happening within there. And the catchment population is usually not well defined within the health facilities. Sometimes even in our microplans, they're not even being captured because they spring up every day in different areas. And from time to time, we need to go around, do a walkthrough to ensure that they're being captured, but most times they are not. Next slide. So with our increasing urbanization within the state, we've been seeing disease outbreaks springing up, and mostly in the slum areas that we have within the state. So even though we've had what we'll say is good coverage, because Lagos State has ranged between 70-something to 80-something%, over the last couple of years, we still have a high number of unimmunized and zero-dose children. And with that, we've had about 7 disease outbreaks in the last 1.5 years. And some to mention are, of course, the circulating vaccine-derived poliovirus. We've had measles outbreaks that we've had to deal with, yellow fever, and countless times we also have cholera outbreaks, which springs from poor sanitation. Next slide. So I've gone just to show us what our comparative analysis of the Penta 1 coverage has been since 2017 till date. The Penta 1 coverage has been suboptimal. We always expected to at least get to 85–90%. It was only in 2018 we got to about 83, but we basically ranged between 70 and 85%. I've also put the coverage that we've had, the annualized coverage up until August, which is 51%. And then looking at our zero-dose children, from 2017 to 2019, there was a decline, and then of course it went up in 2020, which is understandable with the COVID pandemic. There was a slight decline last year, and then with a couple of interventions that has been supported by UNICEF along with other partners to the Lagos State Ministry of Health and Primary Health Care Board, we've had a decline to about 92,471 presently. This is just to provide some insight into the 2021 mix that came out a month ago. And I'm just trying to show basically that Lagos has been doing well in comparison to other states. And from what we can see, we are actually the second highest with the Penta 3 coverage at 85%. But this just shows that with our high population and urbanization within Lagos, despite the fact that we have this coverage, we still have a high number of zero-dose children. So Lagos State was one of the states that implemented the pilot integrated non-polio SIA campaign in June and July of this year, in which we integrated measles vaccine, vitamin A supplementation, COVID vaccination, as well as RI vaccines. And this slide is just showing what our RI coverage was during the time. And with that, we were able to reach, with RI vaccines, a lot of children that won't have met just through the routine fixed posts and outreaches, but leveraging on the campaign to reach them as well. So I think that was part of what we could attribute to have reached the high number of zero-dose that we have in this year. So going on to the strategies that what prompted us coming up with an urban strategy for Lagos. The Lagos State Primary Health Care Board was supported by partners, which included UNICEF, WHO, CHI, along with others in Lagos, just to understand what were the barriers to immunization service delivery, coming from both the health facility and community perspective. This was conducted using FGDs and key informant interviews in 11 LGAs that have been identified on the left, and then you can just go through them. And we had 26 focus group discussions as well as key informant interviews. And we also included inclusion exclusion criteria, just to give you a brief guide, which you can look at as we go on. And the data analysis was also being done basically using coding, and it was transcribed, coded, and analyzed. So this is just a summary of the findings from our focus group discussions and key informant interviews, just trying to understand what were the drivers for non-use of or for not assessing immunization services. And we can see from that that more than half of the caregivers actually assess child health services, ANC, and delivery services. Half is quite a small number, as we understand, for Lagos that has a high population. And the source of information for immunization was majorly from health workers and media. Went on to understand what their barriers to accessing PHC services were. And mostly it was poor health worker attitude that hampered them from using the services, as well as the long waiting times. These were the major barriers. Lagos State in recent time has been having a huge human resource drain, with most of the health workers moving on to what they would deem greener pastures. And with that, we have huge human resource gaps. So even the health workers within the facilities are too few to provide these services, and which causes the patients, or rather the clients, to wait long to access services. Also, the health workers also get tired, and sometimes the attitude towards the clients is not what is expected of them. Some of the other reasons that were ascribed. So going on to some of the efforts that the state decided to implement to have what is called the state urban strategy. And this was just to respond to the suboptimal coverage. And this was being done in 11 LGAs that are deemed the zero-dose LGAs in Lagos State. So it was put into the thematic areas ranging from management and governance all the way down to monitoring and ensuring data quality is improved. So what we did was we leveraged on what we had in terms of coordination by supporting to strengthen the technical working group, which is being called the CERIC within the state. And with that, we instituted at LGA level that they developed their room microplans. Room microplans are usually developed every year, but we actually ensured that they did a walkthrough and this was being updated. And so far, they actually update this on a quarterly basis. Also, we ensure that monthly technical working group reviews are being done, and not just done at state level, but being done at LG level as well, so that they can actually look at their performance over the previous month and institute corrective actions. When it comes to human resource for health, what we did was we supported with the building capacity of the state on the zero-dose strategy, as well as interpersonal communication. This was quite key, especially with the results of the assessment that was being done. With the HRH gaps that we're seeing, we leveraged on the human resource that had been gotten for COVID vaccination and used that to also provide support when it came to the zero-dose strategy and basically for even routine and PHC services within the PHCs. And some other partners have been supporting the state when it comes to the immunization academy and repaired learning, and this has been instituted in the state to ensure that the healthcare workers continue to have continuous professional development. A key portion that was quite important as well was the community engagement strategy within the state. We also supported with ensuring that the LGA health educators were trained so that they could come up with their own community engagement strategies by LGA, and because it's not one size fits all, it also has to depend on it also depended on the population dynamics that they had, and especially in LGAs that had high influx of migrants, we also had to ensure that this was being done. We also strengthened community to health facility linkages so that they could also ensure that they identified and tracked defaulters. And of course, with community influencers, ensuring that we raised their awareness so that they could also get this down to the community and improve demand for services. For the vaccine supply logistics, we just ensured that vaccine delivery was being done to the last mile. And with that, the state has a push model in ensuring that vaccines go to the last mile and is calculated based on vaccine consumption. And the LGAs are also instituted to ensure that they manage their cold chain equipment properly. For service delivery, what we've done is that we implemented 3 rounds of LIDs in the 11 high-dose, zero-dose LGAs. They're having weekly integrated outreach sessions, which are supported by UNICEF. And another thing was engaging the private health facilities who offer RI. About 70% of our health services are being conducted through private health facilities. So they're a key part of this strategy as well. And for caregivers who are working We also ensure that in the comprehensive health facilities, weekend operations are being conducted. To ensure data quality and that data is being captured, routine immunization supported supervision is being done, in which we look at their data, ensure that they're capturing the data properly, and of course, ensuring that time is being submitted timely so that it's actually being captured in the system. Next slide, please. So some of the lessons we've learned is that whilst this has more or less been a trial, it needs to be endorsed by the State Primary Healthcare Board. And we'll look at the lessons that we've learned from what has been implemented and fine-tune it better to ensure that the state has a context-specific urban immunization strategy for the state. And this has to be done with development partners and particularly with the private sector for Lagos State. We need more private sector involvement in immunization, especially when it comes to vaccine supply, logistics, operations, in social and behavioral change, and even in terms of opening up new vaccine sites, because as I mentioned, we still have about 124 wards without PECs. There needs to be a key focus on community engagement to improve how we can reach zero-dose children and actually have them coming and access the important PEC services that are being given in our PEC services, in our PEC centers. We need to continue to ensure that we monitor using our mobile apps. We use the mobile apps when we do our supported supervision. And this has really helped with our real-time monitoring. But we also need to look at how we continue to fine-tune it and make it better in terms of strengthening our data quality. We need to ensure that the institute weekend vaccination services, this has worked already and is something that needs to be spread even outside of just the comprehensive centers to others as well. And there needs to be improved synergy when it comes to routine immunization and a lot of our supplementary immunization activities. We saw that this worked with the integrated campaign that we had earlier on the year, and it's something we need to do a bit more of when it comes to even implementing our OBR campaigns. We need to start to integrate this with routine immunization as well. So I think this is some of the lessons that I brought from Lagos State. Thank you very much.
Thank you so much, Ijoma, for this exciting presentation. I know our participants have a lot of questions and comments. Please feel free to add your questions, comments within the chat. So next, we move to Zimbabwe. Nasser, please come in and give us within time the assessment of inequities in routine immunization. Over to you, Nasser.
Thank you, Ibrahim. Good afternoon, colleagues. Good morning for those who are in different time zones. So I'm going to take you through the assessment of inequities in routine immunization among urban poor communities. We did this in 4 cities, as you can see: Harare, Chitingwiza, Bulawayo, and Kwekwe. And we did this in 2020 during the time when the COVID is at peak. So next slide, please. So just to give you a bit of a background of Zimbabwe, as I said, we did this in 2020. So when we look at the coverage back in 2018, at national level was 89%, but also there was an increasing number of unvaccinated in districts with emerging and unplanned urban settlement, which was reported. But also, according to Zimbabwe DHIS 2015, shows that the cities that I've mentioned, at national level, they had 10% of unvaccinated children. But as you can see, the cities that I've mentioned, starting with Bulawayo, there's 2.5, and then Mashingo has 20.7% of unvaccinated children. So you can see that despite the high coverage, but still there are some of the cities like Mashingo, they have a high number of unvaccinated children. So as you know, most of the time, the urban areas tend to report high coverage, and that sometimes masked the unvaccinated children. And this is contributed by the fact that usually we have a problem with denominator when it comes to urban areas where people are coming in and out of the cities. So it's not clear in terms of the target population, and at the end of the day, it affects the coverage reported. So the aim of these studies, the finding of the assessment was mainly intended to provide basis for the Zimbabwe to make their strategies in terms of reducing inequities among the urban poor. But also the findings of the study, though it happens in 4 cities, but the findings is also expected to be used by other cities within Zimbabwe as well as other countries. Next. Next, please. Yeah, so the overall goal of the assessment we did was to, as I said, was to identify the and under-vaccinated children among urban poor area, but also reveal the intra-urban differences in routine coverages, highlight the main reasons for low access and use of routine services, and of course, then make some recommendations to increase the coverage for this population. So specifically, we are looking at the vaccine status among children aged 24 to 35 months in those areas, but also identifying associated factors for and under-vaccinated, and then develop strategies to address the factors identified. But also share the real-time improvement and experiences with other cities within Zimbabwe. And we did this through community of practice. I will talk a bit in details in the coming slides about the community of practice that we established. And then lastly, to document the best practices and shared with different forums like this one. Next. So in terms of methodology, the situation analysis used a mixed method, and we collected both primary and secondary data. So for primary data was collected from healthcare providers through key informant interview, but also we did 11 focus group discussion with community health workers and 22 focus group discussion with mothers and caregivers. And then for secondary data, we are largely depending on the data set from DHIS2, which the country used to report. So the study cities was selected in collaboration with Ministry of Health as well as Zimbabwe EPI program. And for this sampling, we used multi-stage sampling to identify urban centers and within these participating localities. So the criteria used to select 4 urbans, which I've mentioned earlier, is including the rapid population growth, existence of underserved population, and recently preventable disease outbreaks occurred in those cities. So we look at the city that had outbreaks, but also those cities with increased and vaccinated children. So in each city, the study focused on 3 clinics and their surroundings of underserved settlement. Next, please. So in terms of findings, as per the first objective, we are looking at the vaccination status. So you can see we find out 17% of children aged between 24 to 35 months, they are not fully vaccinated. And 1% were not vaccinated at all, 80% were fully vaccinated, and 2% were had unknown vaccination status. So in terms of the data reported in 2020 for unvaccinated children, it was 7%, and for under-vaccinated children was 14%. But we also looked at the previous year data, as you can see from 2016 to 2019, the number of under-vaccinated trends range from 11 to 14. Next. Next, please. Yeah, so we looked, as I said, we looked also at the factors associated with and under-vaccinated children. So among the factors that associated with caregivers who most likely have unvaccinated children includes those who cannot read and write, those who incur costs like paying more than $1 to reach the vaccination site, and also those who spend time to access vaccination services. But also we found out that mothers who lost their child health cards, they are fearing of going back to the facility, and they're most likely not to continue the vaccination. And then we also find interesting that those employed mothers or caregivers, they are more likely to have unvaccinated or under-vaccinated children. Other reported factors contributed to under-vaccination. Those are including the stockouts of vaccines and related supplies, shortage of child health card, staff shortage, attitudes, and waiting time as well at the clinic. Next. Yeah, so other factors including failure to receive vaccination at clinic on the scheduled visit. We did the exit interview, and about 23% of respondents, they missed vaccination on the day of visit. So you can see Harare is leading with 31.9%, then followed by Chitingwiza, Kwekwe, and then Bulawayo. So those are among the respondents who had a time to visit the facility, but unfortunately, they are not receiving vaccines due to various reasons. So I also put a quote from one of the respondents. Other factors include limited number of children being vaccinated per day. So some of the facility, they set up a limited number, like they set up a number like 100 children per day. So once those 100 children are vaccinated, the rest, they are asked to come the other day. Other factors is vaccine objectors. We have observed in some areas there is vaccine objectors, and this mainly related to religious. And we find out also some of religious objectors, they tend to vaccinate their children, but they hide that and they leave their cards at the vaccination site so that they cannot recognize that they are willing to, or they are getting their children to vaccination. Next. Other factors, it's a competing priority. Some caregivers reported that they cannot leave like going to their work or the activities that giving them, I mean, like those, especially those who are employed, they cannot leave their work and taking their children to the vaccination site. So the competing priority was among the reasons mentioned by caregivers not to take their children. And then we also realized there is a poor linkage in terms of community engagement. We observed, as I said, we did the focus group discussion with community health workers. We observed that CHW included in the recent training in 2020 when we did the assessment, but despite of being trained, they lack some of the pertinent information like the recent new vaccines added into the schedule. The other issue is the clinic had committees, health committees, but due to COVID, during the time when we did the assessment, all the committee were not functioning. Next. Yeah, so some of the strategies that we also identified during the assessment, during the discussion with caregivers, CHW, and other stakeholders, it includes strengthening regular immunization services, both through fixed and outreach services. And this was because we identified a lot of cancellation of sessions. So in line with that, we suggest to, one of the strategies to make sure that there is adequate staff, but also reliable transport for those who are going to the outreach sites. And then the other is to ensure availability of adequate vaccines and related supplies, strengthening community linkage through community education, mobilization, and also infant tracking, and then recruit more CHW to enhance the linkage with the community. But there's the other strategy that we are thinking to be put in place is to integrate outreach with other programs to extend EPI services to more areas. we realized that there are some outreach services which are also going on with other programs. So it will be good to have integrated outreach so that we can extend EPI services. And then the last one is to really do like regular catch-up campaigns or periodic intensification in those areas with high number of and under-vaccinated children. Next. Yeah, so as JSI, we didn't do the assessment and leave the way it is with the findings, but we have tried to support some of the activities despite the challenges that I will mention in the next slide. So we supported the development of city-specific action plans. As I said, we did this in 4 cities. So as you know, we cannot have a one plan for all the city because the action plan need to be specific to the city. So we supported this, and then we also supported the development or updated of the micro planning at the facility level in all 4 cities. And then we also support the consolidation and documentation of best practices and lesson learned. And as I said, we shared this through a community of practice, which was established. Next. But also we established community of practice, as I said. The aim of this was to share the experience from the 4 cities with other cities in the country so that they can adapt the tools, the methodology on how to conduct the assessment, how to set up the strategies, and how to monitor the progress of un- and under-vaccinated in those areas. So several members were identified from other 9 cities apart from those 4 which we did the study or the assessment, and then we orient them. We also determine the preferred communication channels where the community of practice can operate. And then 60 members was identified and formed the group, and the community of practice was launched at national level. And it includes also other partners like WHO, UNICEF, Crown Agent, and others. So multiple sessions were held through Boost platform, and the aim was to share the experience, as I said, from the assessment, but also to share the tools, the methodology with other cities so that they can also do their own assessment. Next. Yeah, so in terms of challenges, as I said earlier, we had limited short funding because we did this through Gavi funding. And as you know, usually Gavi funding is limited in terms of the amount of money, but also in terms of time. So we also experienced challenges in delayed the implementation due to competing priorities, but as well the COVID issue came in. The other challenges was lack of funding to implement some of the recommendations. As I said, you see, we have somehow tried to support some of the activities, but we didn't manage to go to the list of the strategies that were recommended. And then for the community of practice specifically, we had some challenges in terms of participation due to various reasons, including connectivity, but also we had some lack of regular participation among the members. So we think for this to happen smoothly, we need to have a support beyond the assessment so that the recommendations and the strategies can be implemented. For the COP, since it's a new concept to both Ministry of Health and the cities, we think this need more time and effort to persuasion, but also we think this need to be, the assessment need to be linked with Gavi HSS and also the alignment of the Ministry of Health immunization program to address urban needs, and then strengthening absorptive capacity and technical management with the Ministry of Health and EPI program to lead this initiative of urban immunization. Next, that's going to be my last slide. So in conclusion, we think that implementation of urban immunization need multi-sectoral and multi-partner collaborations for it to happen, but also more resources in terms of human and financial resources need to be allocated to address inequities in poor urban areas. The issue of community linkage is very vital in this. urban immunization, since, as you know, there's no like size, one size fit all. Each urban area has its own characteristics. So it's really important to have a community linkage to make sure that you come up with appropriate strategies. And the last, but not least, the short-time implementation period of funding through mechanism like Gavi was really a limitations to implement the strategies beyond the assessment. Thanks.
Thank you, Nasir, for this wonderful summary in terms of the presentation on the experience in Zimbabwe for cities. So I see a lot of questions are coming in. Just you can be looking at the charts while we move to the next presentation. Please, after, come and share with us the experience from Pakistan. Over to you, after.
Yeah, thank you so much, Ibrahim. Good morning, good afternoon, and good evening, colleagues. I will be sharing one of our strategy or implementation kind of strategy that how we reach this these zero dose children. So I will start where my colleague Nasser mentioned while thanking Gavi. Thanks to Gavi Vaccine Alliance for supporting this whole national immunization project specifically, and then in the middle of project when we came to know that we have some limitation in urban immunization, so we added one additional DLI for urban immunization equity and coverage, and that's first time in 2017 this work was initiated. This targeting of urban slums and these communities were initiated in mega cities. Next, please. So urbanization, Ibrahim mentioned why its priorities, and with this increase in urbanization, we were having increase in development of these urban and peri-urban slums. In Pakistan, more than half of urban population was residing in 10 mega cities based on the census, and out of those city populations, more than half, around 32 million, urban population is living in these kind of temporary slums, urban and peri-urban slum areas. And those slums have the same characteristics as shared by my other colleagues, and we have significant proportion of our less than one and zero dose children in these mega cities. Next, please. So our urban health initiative, totally when we strategized this strategy, it was based on the global urban toolkit with main strategic objective like addressing government that this needs to be led by government and government owned initiative, not a kind of stand alone project, short time project by partners. And we ensure that it's a kind of gender sensitive integral part of immunization system. And then context specific, because we were having different context in different mega cities, like in Karachi, totally different context, and Peshawar, totally different, in Quetta, Lahore, all these provincial headquarters we selected among those 10 cities where we for targeting of these zero dose children, and only Karachi was having around 40% of all those zero dose children in one city. Then the key point, we also wanted to have a kind of synergy and capitalize on the available polio resources, and we shift from that vertical delivery to a kind of integrated service delivery approach. I mean, mainly immunization services integrated with basic immunization services, and based on partnership with CSOs, civil society organizations, private service providers, both in demand generation and in service delivery. And then the last but the most important, we prototyped all these to have a kind of structured community engagement and which is sustainable through slums, community health committees, and all those prototypes. So this initiative leads us to kind of know regarding these zero dose children, that who they are, where they are, why they are not accessed, and how we can reach them. So based on this, to know that who they are and where they are, we conducted urban slum profiling in these mega cities. Where we profiled, next please, where we profiled around 4,500 urban and peri-urban slums, and also the underserved areas. We defined underserved areas, all those areas which have low immunization coverage, high zero dose children, but they are not slums. They are, just in with very developed kind of colonies and sectors of those mega cities. So I enlisted all those activities which we conducted in those areas, and the Gavi Sport, all other partners who supported, JSI supported a lot and submitted this urban immunization strategy for Karachi to government. But the government, and we are still on follow up with them to get it ratified, and so that government can allocate financial resources. But all those activities which we define, which we agreed in those strategies, we started implementing. Next please. So all these activities are enlisted here. So today I will be presenting one of the initiative, which is 24/7 bird dose initiative, which we implemented in these maternity homes in in these mega cities. Because during bottleneck analysis, we came to know that a lot of deliveries, they are being conducted at big hospitals, but they are not covered. So if 4 to 5 hours in 10 hours they used to discharge them, and then it's a tradition in Pakistan that once the mother discharged, or after delivery, they stay inside home for 40 days. So that's how we used to miss them and increase the number of zero dose. So that was a kind of missed opportunity which we targeted to have kind of 24/7 vaccination sites within labor room and to vaccinate all those children. Next please. So yeah, first I mean, based on NETAG also kind of recommended to do this. It was tag recommendation, one of the tag recommendation also, and it also provided us public-private partnership opportunity, and we integrated this with kind of basic SBC package, and we also started birth registration here from these newborns. Next, please. So the key activities we next these are all the things. I mean, we were having this bird dose initiative. It was having two components. One was facility based. The other one was community based. So what I will be sharing here, this will be community based, which we started in one hospital in February 2020, and then in mid of 2020 we expanded to 4, and now we have these sites functional in 48 sites in 4 provinces and areas. Next, please.
Sorry, just could you slow down a little bit, please, for the interpreter?
Yeah, sure.
Thank
I
you.
will try.
Thank you very much.
Because I received message that I have left with 4 minutes only.
Yes, yes, yeah, I know.
Okay,
but,
sure.
Yeah, thank you.
So so I will next, please. I will share this facility-based component. 70% deliveries are facility-based, and these are the key activities which we're conducting. Initially, assessment of the hospitals, then coordination meeting with all the stakeholders, followed by the assessment and sensitization of labor room staff, and then provision of all those resources required: cold chain, vaccine, training to HR, introduction of female vaccinators, and then to start this vaccination from labor room. Next, please. So these are now at this point in, these are the sites. In total, we have 48 sites which are functional both in the public and private sector in these provinces. These ICT, Gilgit, HAK, KPK, Balochistan, Sindh, all in these, and these are the provinces where we have these sites. Next, please. So these are the results. I mean, when we started, we conducted baseline and we found that for BCG, the coverage was around 16%. So in all these areas in the country, the newborn which were vaccinated, now they are for OPV and BCG, we are achieving more than 90% coverage in these areas. Next, please. And around more than 200,000 newborn have been vaccinated up till now in these areas, starting from year one, because we were having limited number of sites. In 22, we expanded, and now overall, out of those 215,000, 224, yeah, total live was 225, 26,000, 215,000 have been vaccinated, and all those vaccinated, then they are referred to their local community health workers, who are then following them. In one of the province in Sindh, we have linked this with their EPI MIS. Through EPI MIS, now we are tracking them and following those through their respective vaccinators to ensure that they complete their vaccination schedule for all antigen. Next, please. So the key challenges which we found, thanks God and thanks to Gavi, there was no issue in financial resources. But the tracking mechanism, there was no. It was really challenging in those areas where we were having no EPI MIS. So now the solution is being developed to track them. If we are not tracking them till completion of their RI schedule, then it's a kind of challenge. And then availability of female vaccination staff, and then especially BCG vaccine wastage was kind of one real challenge, which we mitigated with several corrective actions. And in a way forward, number one, we are establishing functional tracking system, not separate one, as an integral part of the existing system. And rollout of these tertiary care hospitals, maternity homes, and district hospitals, including private sector in this currently ongoing PFFR, this full portfolio planning. All the provinces, they recommended that they are going to expand it in all those maternity homes which have at least more than 10 deliveries in 24 hours in hospitals. And yeah, then establishment of home-based model for implementation and documentation of lesson learned. That's a kind of a way forward. Next, please. So with this, thank you so much. We are available to kind of respond if there is any question. Over to you, Ibrahim.
Thank you so much, Aftab, and thank you so much to the presenters. We've seen Ijeoma presenting urban immunization strategy, development, and intervention in Lagos. We did a lot of questions around that as well in terms of how some of those things materialize and what is the status. We've seen Nasser presenting the work in terms of assessing zero dose in 4 cities within Zimbabwe, the community of practice, how the need for multi-sectoral collaboration to reach zero dose. And then now, after wrapped it up with 24/7 interventions, trying to make sure that children have access to vaccines 24/7 from delivery. We have, thank you so much. We have a lot of questions from the audience. Rachel, you want to comment in terms of some of the few curated questions?
Yes, thank you. And there's a very active Q&A chat, and really appreciate the panelists also coming in to answer these as we go along. I wanted to raise a few of these before we open it up. The first one is for Nasser. If you could please elaborate on the cost for vaccination faced by the urban poor, which you alluded to, some of them having to pay more than $1 a session. Could you explain a little bit more about that, and were there any solutions proposed for this barrier? Thank you.
Yeah, thank you, Rachel. So this is associated with the transport cost, because what we identified, most of the urban poor areas, there is no health services in terms of the health facility that providing immunization services. And in most areas, there is either no outreach session planned, or the outreach is planned but not conducted regularly. So the caretakers has to travel all the way from where they are staying to the health facilities, and they have to pay for the fare. So that's $1 I was talking about is mainly transport for the caretaker to take the children to the health facilities. So in terms of strategies to overcome that is there is a short-term solution for that is to make sure that there is a planned outreach and conducted regularly. So it's up to the health facilities now to again link with the community and plan for the outreach in that particular area. So we have supported the facilities as well to replan their outreach plans so that they can establish outreach in those kind of areas. But again, in the long run, there is a need to also build health facilities in those areas. Thanks, and over to you.
Thank you, Nasser. Just quickly to Ijoma, I see there a question with respect to operationalizing the weekend vaccination as well as evening vaccination, if you could comment on that. And then the role of private sector, how you're able to engage the private sector and what is their specific role, and also comment on the status of the urban immunization strategy in Lagos, just briefly. Over to you, Ijoma.
Okay, thank you very much. I'd actually even replied in the chat box. So for the weekend vaccination, as I mentioned, they're actually only being provided in the comprehensive health centers, in the LGAs. So these are the centers that provide 24-hour services. The challenge that we've seen is with the reluctance by the healthcare workers to open vials for a few children, especially for BCG, and we'll understand why, which is to reduce wastage. So usually they ask the caregivers to return on the weekdays, which kind of defeats the whole purpose of the weekend vaccination, which is mostly for working caregivers who can only come on the weekends. But this has always been emphasized to them during on-the-job trainings, or when we do support supervision, or even during, formal capacity building activities, that once the child is seen at a facility, you open the vaccine vial and the child is vaccinated, because that becomes a missed child. So this is something we just continue to emphasize, but that's, I would say, is one of the major challenges that we've seen with weekend vaccinations. I would say maybe the other challenge is the fact that it's limited because it's just one per LGA. So this is, of course, far for some caregivers. But I think the only major challenge we've seen mostly has been around reluctance to open the vials. For the specific role of the private sector in Lagos to improve coverage, we've seen limited support from the private sector when it comes to immunization. But there's some identified opportunities that are being brokered by partners with the Lagos State government. And it's mostly been in coaching and vaccine logistics, ensuring that vaccines go to the last mile. So that is one area that I know that we've seen, or at least we're seeing opportunities for support to immunization. Sorry, what was the last question? Trying to look
the
through.
Status of your urban strategy in Lagos.
Okay, it's basically being implemented presently. We're still having the integrated outreaches being done weekly across the 11 LGAs identified as zero-dose LGAs. And across all the different thematic areas that I mentioned, we're still implementing them as well. I know there are still challenges when it comes to funding. It's mostly donor funded, but this is something that we continue to work on, especially having advocacy to the government to take more ownership when it comes to tackling zero-dose children in the state.
Thank you, Ijoma. After I see a question with respect to, is there a tracking system for tracking beds or bed within the country, and how that is helping the system to be able to reach all these children with vaccines? Do you want to come in and respond quickly?
Yes, thank you so much, Ibrahim. This question, there was two questions. Number one, regarding how LHWs, they are identifying community-based births. Yes, they have all these community-based birth recording and registration system in place. But what we did at this point in time, we initiated a kind of household level detection and referring of these zero-dose children and pregnant and lactating mothers. We did it in as a prototype. Now we will be expanding it to other areas. And LHW, they also have for their community all those registration. But the issue is that urban areas are not entitled to have LHWs, lady health workers. They are placed in rural areas of Pakistan. So now we have all those community health workers by other programs, some polio program, frontline workers in some areas. LHW, we are utilizing them. And now we are moving this. Initially, it was paper-based, the prototype, and then in one union council, we digitize this whole system. And now we are linking this to existing EIR system. In one province, we have that existing EIR system, and in other provinces, the government is going to implement, and this household level tracking will be linked for them, and we will use the same system to implement and to record and all those, the second limb of this whole framework, that detection and recording of children from household level. So I hope I answered your question. Over to you, Ibrahim.
Thank you so much, Aftab. I see there are still a lot of questions coming in, but we're already over time. I think there will be plan to respond to all these questions and share links, including the recordings with colleagues. But let me hand over to Alex to wrap up. Alex, over to you, please.
Yes, thank you very much. Yes, a lot of questions are remaining. We will see if it's possible to have them, to have some answers in written. I will see with you guys by email. In any case, thank you very much for this very interesting presentation. And I hope everyone enjoyed the content at least as much as I did. This is the last session of this series. And in the meantime, well, I mean, we will send all the links to the recordings as well as to the slide so that you have access to the material, to this webinar material. And yes, so thank you very much for following this webinar series. You can, we will send you a link to the community of practice of zero-dose children by email to all. And if you have any question, then you can always contact me by email. So thanks a lot, everyone. That was a great webinar series, and this session was excellent. And I wish everyone a very nice rest of the day, and we'll keep in touch and hope to see you in another TechNet 21 webinar or on the Zero-Dose Children Community of Practice. Have a nice day, everyone. Bye-bye.
Bye.
Thanks,
Thank
Ibrahim.
you. Bye-bye.
Bye.